Okay, class. So welcome back. In this unit, we'll get into some of the congenital defects, or at least more common ones you might encounter in practice. The first thing we want to unpack is that there are two general types of congenital heart defects, right? So we have acyanotic defects and then cyanotic defects. So acyanotic defects are conditions where perfusion to the periphery, right, is still normal, right? So the child has a normal pinkish color or they're well perfused. And here's three of the ones that we have listed here. So atrial septal defect, patent ductus arteriosum or arteriosus, PDA, and then ventral septal defects. Cyanotic defects are conditions where there is low oxygenated or deoxygenated. Again, I don't like to use the word deoxygenated because there's never not any oxygen. There's always a little bit, but we'll use that for this term, low oxygenated or deoxygenated blood, getting out to the periphery. So the baby will have a bluish appearance. I have two conditions that are in purple: ventral septal defects and coarctation of the aorta, depending on the severity of either condition. So ventral septal defect is where we have an opening in the ventricles, and the coarctation of the aorta is exactly as it sounds, narrowing of the aorta. Depending on the severity of these conditions, they can become a cyanotic type defect from previously being an acyanotic defect. So they can be a little bit mixed bag, but I have these kind of mixed here. So just bear in mind, that some conditions can technically be a bit of both, but VSD is typically viewed as acyanotic, and coarctation, again, we may even see it in this side as well. We'll get into it a little bit. So how we often categorize these, the first screening that a child will get is when they're born is the APGAR score. So the APGAR score is a quick test performed on the baby at 1 and 5 minutes after birth. The 1 minute score determines how well the baby is tolerating the birthing process. The 5 minute score tells the physician how well the baby is going to do outside the mother's womb. Now, normally the score we're looking for is 7 or above. A score of 10 is pretty unusual since almost all newborns will lose maybe a point for slightly bluish hands or feet. Scores below 3 strongly associated with some sort of developmental, some congenital cardiac disorder. And in some rare cases, we may see the test performed actually 10 minutes after birth too. So basically, we want the baby, and APGAR is an anagram for appearance, pulse, grimace, activity, and respirations. So basically, when a baby is born, we want to see them pink, high heart rate. We want to hear them crying, being able to respond to stimuli, their arms flex, they've got some tension, and then a strong cry as well. So it means that they're should be kind of pink and squirmy, basically. That's a sign of a baby that's healthy. And again, as we move further down the scale to 0, right, we get more to a baby that's not as responsive, not as active. The heart rate's a little bit slower, and the skin's a little bit bluer, right? So that's not a good sign. And again, we're looking for a 7 or above, right? It's very rare for a score to be 10. And then anything below a 7, we get kind of concerned. And then maybe a baby's rushed into the operating room and look for the defect. The good thing is a lot of these defects that we're identifying in kids, we're able to identify them in utero. So these kids can be pre-screened, and as soon as they're ready to breathe on their own, and we can kind of get them back, and when they're born, we can get them to the operating room pretty quickly. And there's even some facilities as well. I believe Shands, Jackson down in Florida. I think Vanderbilt in Tennessee. A few other places are even doing, I think CHOP as well, Children's Hospital of Philadelphia, are doing in utero procedures. So we're able to correct some of these defects even before the kid's born to prevent, again, these things typically manifest at birth because now the kid is breathing and perfusing on their own. If they get a defect, they're going to have some problems. So what causes the presence or the appearance of the cyanosis or acyanosis in kids is the formation of the shunt and the direction of where that shunt is going to. So a left to right shunt, right, so is a defect, but we have oxygenated blood that's going into the periphery and maybe spilling into the right circuit. So we've got the left shunting into the right, right? So the systemic circuit, the left circuit of the heart, remember, think of the heart as a double pump, a left side, a right side. Left side goes out to the body, right side going to the lungs with the deoxygenated blood. In this example, we're still getting oxygenated blood or highly oxygenated blood out to the periphery, and maybe we're getting some mixing going back into the lungs. So the shunting is going from the left side to the right side. And then we have right to left shunts, right, where we're getting we're getting deoxygenated or low oxygen blood from the right side, the pulmonic circuit, which would normally just go to the lungs, is now spilling into the left side or the systemic circuit. And there's a cyanosis, right? There's too much low oxygenated blood or not enough oxygen in the periphery because there's deoxygenated blood. All of these operate under that again, we can go back to physiology, downhill gradients, or again, this concept of pressure rules. Pressure goes from high systems to low systems, right? So wherever we have a higher system, if we have an opening, it's going to spill into the lower pressure chamber. And this will make more sense when we go through some of these conditions. So the first one we'll get into, and I've got these color-coded for you guys to make this simple, just help you remember, is a patent ductus arteriosus. So like we mentioned in the first unit, typically the PDA involutes and closes at birth within hours, right? We need it when we're a baby to prevent that blood flow from getting into the lungs. But when we're breathing on our own as a newborn, like we don't need that anymore. We actually need blood to be going into our lungs. So the PDA creates a left to right shunt, right? Because now, right, we don't have that foramen ovale, we don't have the placenta, we're pumping blood, right, on our own, right, coming back from the lungs, through the pulmonary veins and the left ventricles out to the periphery. With this PDA present, right, because the pressure in the aorta is much higher than the pulmonary artery, remember, the aortic pressure is typically somewhere around 100 mean, and our pulmonary pressure is typically no more than about 20 to 25 millimeters of mercury, right? Blood is going to shunt from the left side, the left heart, left side, into the lower pressure right side, right? So we create a left to right shunt. But we still have high oxygenated blood going out to the periphery, going to the brain. We get some mixing, right, in the right circuit, but peripherally, we're fine. We're getting oxygenated blood elsewhere. What this causes, though, is the pressure in the right side to be higher, which can lead to increased ventricular work. So the right side, again, thinner ventricles, not supposed to be working against high pressures. Again, the pressure in the pulmonary artery is typically about 20. Pressure in the aorta is typically about 100. Right, the right ventricle is not designed to work against high pressures. It's really 0 to 20. It's not supposed to be high at all. Ventricular walls are thin. If this pressure is elevated, it could lead to right heart failure or right heart complications because the right ventricle has to work a little bit harder. Clinical presentation: the kid might fatigue quickly. They might be susceptible to pneumonias because maybe we end up getting this high pressure, increases filtration pressures in the pulmonary circulation, because again, the pulmonary arteries go into the lungs. You have higher filtration pressures or excessive fluid too, because we have more fluid going from the aorta now into the pulmonary circulation. Could lead to buildup of fluid into the lungs as well. This may require surgical interventions. There are some, I think they're even working on some medications now they can give the kids to help kind of close this at birth. But again, PDA normally should close. If it's open, we're going to shunt blood from the aorta into the pulmonary artery. It's an acyanotic defect, left to right shunt, because aorta to the pulmonary artery, blood's still going out to the periphery with normal oxygenation. We're just shunting some blood now into the pulmonary circulation, which may raise pulmonary artery pressure and potentially cause backflow even into the lungs, lead to excessive work on the right ventricles, and may lead to heart failure on the right side if it's severe enough. The next condition we'll talk about are atrial septal defects. So blood flowing between the atria. Right? So we get a defect here, right? So remembering, again, the left side pressures are going to be higher than the right side, right? So if we have high pressure here, low pressure here, right? Blood is going to shunt in this direction. So what may happen, again, remembering what comes with blood, right, and moving through the cardiovascular system, there's a pressure and a volume, right? So we may cause excessive stretch as well. That pressure jet comes along with that flow of blood, may lead to excessive overload of the right ventricle. So again, we'll still get blood flow out, into the aorta that is high oxygen because the shunt's going this way. We're not getting any, much mixing, and normally oxygenated blood's still going out to the periphery, but we may cause some volume overload to the right heart and potentially backflow if this pressure buildup and volume buildup's high enough, potentially into the pulmonary circulation and maybe even back out into the even to the vena cava, potentially causing some peripheral swelling too. So again, if it's not addressed, you may see a shortened lifespan. It's usually repaired 4 to 6 years again, but these kids will come out still looking with normal pink colored skin because again, we are still getting normal perfusion to the periphery. It's just that we're getting, high oxygenated blood into the right circuit where it shouldn't be. And then we have ventral septal defects, right? So it's actually one of the most common defects. Small defects might actually close on their own spontaneously. Some may require some surgery. Again, typically forms a left to right shunt. Again, same rules apply as the right side or the atrial septal defects. Again, the left ventricular pressures are higher, right? Are higher than the right side, right? Use a high pressure system. Again, low pressure system. So pressure is going to move from high to low. We had a left to right shunt. All right, so we got oxygenated blood moving into deoxygenated blood or low oxygenated blood. So we still get normal blood flow out to the periphery. So the kid is acyanotic, still pink colored. But we may cause pressure and volume overload to that right ventricle, right? Because too much volume in this chamber, that pressure jet comes along with it, which may cause some stretching and deformation to the right side. There is also potentially, if this is severe enough or maybe prolonged enough, that the pressure on the right side, because of this defect and this overload, eventually becomes higher even, right? And then starts shunting blood this way, right? It's forming a right to left shunt. This is Eisenmenger syndrome, where now this normally left to right shunt becomes a right to left shunt. So again, we view VSDs typically as an acyanotic defect, but in Eisenmenger syndrome, it can actually become a cyanotic, right? A blue defect. If the pressures in here eventually get so high, they start shunting back the other direction. And then there's coarctation of the aorta. So coarctation just means pinching of the aorta, right? It's usually distal to the subclavian vein. Severity depends on the degree of pinching and location. Sometimes the kids may end up being acyanotic, and this may not be detected until much later in childhood. Typically, you see a kid with unexplained hypertension or maybe a pulse differential, so their pulse is in the upper extremities, maybe a little bit higher than the lower extremities, or side to side. We think this is because the elevated blood pressure, maybe because of the low perfusion to the kidneys. That's really these factors to increase perfusion. So these kids will have hypertension despite having no noticeable risk factors. Generally, any kid with hypertension, again, I've given you guys the guidelines for blood pressure in kids. This is, and there's published guidelines from the American Academy of Pediatrics. A kid with hypertension, a lot of different reasons for it. None of them are particularly good reasons. So, just investigate them. So again, coarctation just means pinching of the aorta. It's why people who say it's not important to look at vitals when I'm working in pediatric populations, one, congenital heart defects, incredibly common in kids with pediatric conditions that you would be seeing as a pediatric therapist. But even if you're not, you're working maybe at high school athletics, this could be present. And some people may never even pick it up, right? You might be the first person to pick it up. So just be aware of this. Blood pressure is still important for kids, and this is actually one of the more common conditions that you can pick up from just screening blood pressure in a child. So now we'll get into some cyanotic defects, and we'll actually pause here because this gets a little bit more complicated, and then we'll come back to it. So again, we'll get into cyanotic defects in our next section.